Welcome to This Week in Health IT News, where we take a look at the news that will impact health IT. This is another field report where we talk to leaders from health systems on the front lines. My name is Bill Russell, Healthcare CIO Coach and creator of This Week in Health IT, a set of podcasts, videos, and collaboration events dedicated to developing the next generation of health leaders. As you know, we've been producing a lot of shows over the last 3 weeks, and Series Healthcare has stepped up to sponsor and support This Week in Health IT. And I want to thank them for giving us the opportunity to capture and share the experience, stories, and wisdom of the industry during this crisis. If your system would like to participate in the field reports, it's really easy. Just shoot me an email at bill@thisweekinhealthit.com. Now, on to today's show. All right, today's conversation is with Dr. Eric Lee, Medical Director, Clinical Informatics, and Ray Lowe, CIO for AltaMed Health Services. Good afternoon, gentlemen. Thanks for taking the time to meet with me today.
Oh, thanks for having us on, Bill.
Appreciate
you, Bill.
it.
I'm looking forward to the conversation. I think everyone thinks that I only want to talk to large health systems and whatnot in metropolitan areas, although you guys are in a metropolitan area, but I like the different perspectives. You guys are, federally qualified health clinic and community health center. So this will be an interesting conversation for me, just a different perspective. Just to level set, give us an idea of the area and what AltaMed does for the markets that you serve.
Sure. So AltaMed, we are the largest federally qualified healthcare center in California, and we serve about 250,000 lives in the greater Los Angeles, Orange County area. We primarily serve the multi-ethnic Latino market, the underserved communities. Many of our patients are actually 400% below poverty level, and the best communities that we serve.
Wow. So, and you're looking at Orange County and LA. So you guys, give me an idea of what kind of service you guys are still mostly ambulatory or predominantly ambulatory. I mean, give me a little more background on it.
So we got about over 40 different locations in both LA and Orange counties. We provide ambulatory care with regards to pediatrics, family practice, internal medicine, and women's health and OB services. We also have a PACE program and a dental program. So our PACE, we have 8 PACE centers in LA County, and they provide care to those that are 55 years old or older, have one significant life impairment, and are Medi-Cal. Those are the 3 main criteria for to be part of that program. And the main goal of that program is to keep patients living independently outside of nursing homes for as long as possible. To put it in really simple terms.
Wow.
So the goals of all of these different types of clinics and programs will vary significantly over time. And with COVID, it's been a different emphasis in focusing on with regards to the PACE program, what our dental clinics can do and cannot do, and then how we approach primary care. So it's been a different strategy for each of those areas.
Yeah, I was just thinking about that. I mean, you're doing dental. I would imagine dental has slowed down except for emergency care. Is that pretty accurate?
It has significantly. So we're limited to mostly like emergent kind of cases. We are still doing telephone visits for them to help out with health education or dental education. And so that's been, there has been some telephonic outreach.
Interesting. So teledentistry and those kind of things. Yeah. All right. So you're gonna have a different problem set. I mean, I've heard from other health systems that are telling me that essentially the primary care clinics and those kind of things have all but gone completely telehealth. Is that how you guys are approaching that?
Well, it's been a little bit different for us, and I think some of it stems from what you get reimbursed for remote patient monitoring and telehealth. I think it's been the most restrictive set of guidelines has been impacting the federal qualified health centers and community health centers in general. So it started with, your commercial payers and CMS granting reimbursements for Medicare. And just recently, this past calendar year, moved to Medi-Cal. But the Medi-Cal allowances does not stretch to that of federally qualified health centers. So we've had, I guess we've been trying to make spaghetti sauce out of using ketchup packets and trying to figure out how to deal with this crisis. For us, with the 1135 waiver from the Department of Health Services and the California Primary Care Association, granting us equal reimbursement for telephonic visits, that's been our primary strategy in getting that enabled and quickly pivoting and getting a rapid build into Epic for handling telephone visits in 3 days and piloting that and getting that out. It has been our main focus to date, but we are now focusing on the video visit portion.
So Ray, did you have some of that infrastructure built out, or have you had to figure out how to put a bunch of this stuff in place?
Questions is yes. So we've done a lot of technology uplift at AltaMed in the last 2 years. When we basically have to take a normal 50 to 100 people that we'd be telecommuting and scaling that up into the hundreds and even thousands overnight was no small feat. So we did a lot of uplift, leveraging a lot of Cisco work we've done on firewalls and security in order to do the distance working. We put together a templated approach in terms of how we're doing our drive-through clinics. That was some real-time work as well. And we also looked at how do we go ahead and do our collaboration. We're using WebEx versus Zoom in terms of inside of our organization.
That's great. So, but from a telehealth standpoint, did you have a pretty established telehealth program and you just scaled it up, or did you have to do some other things?
No, that's a great question. So, Dr. Lee and I were joining at the hip in terms of defining the digital transformation strategy. So we actually have gone through and looked at what integrates well through Epic, primarily through MyChart. There's American Well, there's video, and there's Cisco Extended Care. So we're actually right on the cusp of actually putting those in place before the COVID-19 crisis happened. So it actually is making us accelerate a lot quicker. I'll defer to Dr. Lee as to what we're looking at doing in the next few days.
Great. Dr. Lee, do you want to expound on where you guys are going to be going?
I think we haven't exactly come to an agreement on the vendor yet. So, we don't want to favor one vendor over the other, but I think we're pretty close to making a decision. And then, I think there's some discussions about how many concurrent licenses we'll be allowing for, or concurrent sessions we'll be having in all of our clinics. And so I think that's the main thing to work out. But I think we have, all of this other stuff thankfully, Ray and I have been working on this for months in terms of getting the strategy in place, doing the shopping, figuring out how we were going to deal with this even before the relaxation of these requirements, because for what we wanted to do, we were not going to get reimbursed at all for any of these telehealth visits whatsoever. And now we have to accelerate because we can get reimbursements. And so, what we found in our clinics to date is that some of our clinics have maybe half the volume, the visit volume that they typically have. I think with the institution of our telephone visit program, we've been converting and trying to minimize or decrease risk for a lot of those in-person, face-to-face visits that don't necessarily have to happen if we can handle them over a telephone. So what we're finding is maybe it's been about 30 to 40% in person, and then we've added about 30 to 40% with telephone visits. So we're up to about 70% of what our previous visit volumes were before this COVID-19 crisis started. We're hoping to add video to be able to bridge that gap and be able to bring us up to as quickly as possible to, what we were having before this crisis started.
Yeah, it's interesting. I think the difference, you're serving the markets that don't have a lot of money. It's not a good payer mix. It's a lot of Medicaid. It's a lot of, and so Medicaid. I think people are sitting back going, well, why aren't they moving faster? Well, you really do have to make sure you're going to get paid for things, because it's not like there's this huge net there that we can just start doing whatever we want and the money's going to be there. I mean, some of the larger health systems in your community might be running real fast at certain things, but they have a huge endowment and other things that they know they can fall back on for that. You guys really do have to make sure that, I mean, you are serving the community, but you have to make sure that at each stage, you're not getting out over your skis or get ahead of yourself, because you guys don't have a ton of margin for error with regard to this.
Absolutely.
Yeah, that's correct. Yeah, and the added complexity on it, because we serve again the primarily Latino community, is we need to make sure that it's all Spanish enabled as well. And when we're talking Spanish, we're talking about a fifth grade level of Spanish in terms of the interpretation, interpreter language required. The other thing we're looking at on the telehealth is what is the near term and what's kind of the longer term answer we're looking at that will actually go through MyChart application, so we can actually serve the televisit through the Epic portal.
Yeah, I just completed an interview with Boston Children's, and one of the things they did is a call just like this. There's 3 of us on it. The interpreter's on, the patient's on, and the clinician's on. So and I said, well, did you do this? It was like, no, we're just doing a Zoom call just like this. It's like we just put the 3 people on, we're having a conversation, we're documenting it over here in the EHR, and we're that's how they're doing it. And there are complex. I served in the same markets. I served in Orange County, so I don't think people recognize the number of languages that exist within Orange County. A third of our visits to our ED were Hispanic, but a good 15 to 20% were different Asian populations that didn't speak English. So it's not like you just need to speak Spanish. There's other populations you're serving as well.
Oh yeah, there's Vietnamese, Tagalog, Mandarin, all those are very rich in the OC. So.
Absolutely. So what do you wish you had sort of done earlier, or could you have done anything earlier to be more prepared for where you're at today?
So I think I would say, Dr. Lee and I, we were looking at the right player and the integration with Epic through MyChart. So honestly, I really wish we had gone faster through that. As we looked at the digital transformation in healthcare, we not only looked at the tele opportunity, but we also looked at the remote patient monitoring. So we're looking at, are we going to go after CHF, COPD? Are we going to go on a pregnancy journey? How does it fit? How does it fit into our existing service lines that we support? And with COVID-19, we have a much more focus, right, to deliver the tele. And we can relax what we're doing around the RPM. So we're looking at the whole ecosystem. So from my point of view is we probably should have moved faster on the tele side. But again, we're trying to figure out which was the best based on quality outcomes, in terms of delivering the transformation of the organization. That's my view. Dr. Lee, what are your thoughts?
Yeah, Bill, I don't know if we could have done that much more differently, to be honest with you. We just went live with Epic Foundation on 8/1/2019. And we did that. We signed the contract with Epic on 8/16/2018. So in 50 weeks time, we went live with Epic, big bang implementation. We had to stabilize. And all along, Ray and I, were wearing multiple hats, because we're not like some of the bigger, larger, well-endowed organizations that have a chief digital officer, a chief, technical officer, a chief, an innovation officer. We wear all of those hats. And so therefore, in our infinite spare time, we had to plan our telehealth kind of strategy and remote patient monitoring strategies. And so I honestly, Ray, I don't know. In looking back, Bill, I really don't think we could have done it any differently. I'm just glad we did all this planning all along, so that we are, if only we had another month or two is probably the only thing I would say.
It's really time if you had a little bit more time, but
exactly.
But yeah, imagine trying to do what you're doing today if this had happened 3 years ago. That would have been, you're on foundation, your MyChart is out there, you've already trained I assume a group of the physicians on telehealth, and so you just had to expand all those programs, which is great. What are you most proud that you guys have been able to accomplish?
Yeah, I'll start. I think from a technology perspective, really being able to mobilize and change the workforce. We put over 50 call center agents out remote. We've pushed over 500 corporate employees to be remote as well. We're doing a lot of video, which didn't exist in the past there. So from a technical perspective, we really performed and completed that in about a week. And I'm also really proud that we set up our first drive-through clinic on day 7 of the crisis, and we have 6 of those open across Los Angeles and Orange County. I can go on and on. I mean, procurement, sizing, et cetera, but we're very fortunate to have been prepared.
That's awesome.
Yeah, I think I couldn't be prouder of our organization. I think we have really strong leadership throughout, and the way we all came together so quickly and set up our core meeting and meet on a regular basis, once, twice, 3 times a day if necessary, to just make sure we're all aware of what's going on and aware of the active issues, I think has been something that I'm proud to be a part of. And then from a provider perspective, for us to pivot so quickly, I couldn't say enough about our Epic team about having to build a new telephone visit type and encounter in 3 days and get it trained with our providers out there, and get it trained and operational and inside of a week really is just something that's truly amazing. Because normally, we know that everyone's accelerating their programs and how they're converting this, but normally this would have taken a couple of months at least.
Yeah. That's fantastic. And I appreciate, that you've been able to do this in this tough work environment that you're in. I see the Little Mermaid behind you and the stars and all those things. It's amazing. I'm doing these interviews and everybody has a different place that they're doing these interviews in. And it looks like you're in your kids' room.
Yeah, it's my kids' playroom. So they old artwork that they've had in the before.
Yeah, and Ray's got the dog going in the background. So we're getting the full experience of the tele.
Yeah, the work from home. Yeah, she never had their dog bark. That's what they say when you're working from home, right?
Exactly. Well, gentlemen, thank you very, very much for your time. I really appreciate you taking the time to spend a few minutes with me.
Thanks, Bill.
You got it.
That's all for this show. Special thanks to our channel sponsors, VMware, Starbridge Advisors, Galen Healthcare, Health Lyrics, and ProTalent Advisors for choosing to invest in developing the next generation of health leaders. If you want to support the fastest growing podcast in the health IT space, the best way to do that is to share it with a peer. Send an email, DM, whatever you do. You can also follow us on social media, subscribe to our YouTube channel. There's a lot of different ways you can support us, but sharing it with a peer is the best. Please check back often, as we will be dropping many more shows until we flatten the curve across the country. Thanks for listening. That's all for now.